Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Welcome everybody to the Low Carb MD podcast. I have an extra special episode. Actually, when I first started my clinic, like 5 years ago, or 6 years ago, 7 years ago now, wow, holy crap, I'm getting old. One of my first medical assistants was the guest I have on today, and her name is Mary Dugandzic, and she's now a physician assistant and went to PA school. But let me tell you a little bit about that journey. So she started, her undergraduate education at Binghamton, also where I went. She, worked here in our office as a medical assistant and ultimately went off to PA school. She went to PA school at Marist and realized that the medical system is not all that it's chalked out to be. We've worked together on a paper that we've published on Cushing's and ketogenic diets, and we've laughed, we've cried, we've had an amazing time over the past several years as I've seen her career progress. And now she's working in our clinic, working on our team, back with our team, which makes me happy because it's like, I can't be all that bad if you're coming back, Mary. So it's that actually brings me a lot of joy. At least it lets me think that I'm not as bad as I think, In any case, thank you for coming, and it's nice to have you here.
Thank you for having me. It's great I've been coming back, as you mentioned, over the past few years, and it's been great. I think the only discrepancy with what you said is I think even before I was at Marist, I kind of started to see the issues with the medical system. Before I came to work with you, I was working at an urgent care, and I kind of saw high volume, quick visits, and I really wasn't sure that going to PA school was what I wanted to do until I came back to your office and I got to see what you guys do in depth. And I don't know that if I hadn't been working at your clinic before PA school that I actually would be a provider now. I don't know if I would have gone a different route or some other way to kind of have that better relationship with patients. So I think
So help me understand, right? Mm-hmm. So here you are, you're an undergraduate. Walk me through what inspired you to get, more involved in the medical field, become a, provider of care, right? What, you're at college, you're like, what do I do? I mean, I know your background, that you come from an entrepreneurial sort of family, and, help me understand what makes you think, okay, maybe I should go into healthcare, maybe I should go into medicine. Like, what is your initial spark?
Yeah, I think everyone kind of goes in because they want to help people. And my sister's a nurse and my other sister's a physical therapist. And I saw their jobs and I saw what they were doing. And I had a really wonderful first experience with medicine. And that was at Burke Rehabilitation Facility in Westchester, which is a pretty well-renowned facility. And I was working with stroke patients. And I was working with them for days to weeks to months. And I really got to see them get better. And I loved seeing the continuity of care. And I was just a nursing assistant. I wasn't a huge part of their care, but I got to watch them get better and like see how medicine was working and helping them. And so during college, then I started taking all the prerequisites to do something in medicine. But then, as I mentioned, I started working for bigger institutions, really quick visits where I kind of lost that continuity of care that I was seeing with the inpatient facilities. And I kind of started to lose that love for medicine. I started to question a little bit about it. And I actually, during that time, became a certified nutritional therapist because I thought, okay, well, maybe this isn't medicine. Maybe I want to do something more one-on-one with patients, health, wellness. But still, I felt there was something missing. I wanted to do a little bit more. So I figured if I could combine nutrition, continuity of care, and the science and medicine, anatomy, physiology that I was loving in undergraduate, that would be a good fit. And then that's about the time that I met you, a friend of a friend. I was telling everything that I wanted to do. I wanted to combine nutrition, medicine, all of these things. And they said, I think there's a doctor not too far away from where you are right now, about 20 minutes down the road, doing something similar. And then that's how I applied to your office.
So walk me through this, because you mentioned, being a nurse's aide and, not a huge part of the medical team, but I think they're one of the hugest parts of the medical team. Little known fact, I was a nurse's aide.
Oh, really?
I was a nurse's aide for several years at Nyack Hospital, which is part of Montefiore.
Mhm.
And I was a nurse's aide at a senior facility. So I've been in the trenches, and I think it's humbling to like see everything from the ground up. I don't think most doctors are ever exposed to that. I mean, I say this like, it's embarrassing. I mean, I have wiped asses, literally wiped asses, right? And not my kids' asses, right? Like I literally, oh, Jack, I don't know if you have to edit that out or not, but I have, but I think it's humbling. I've done EKGs myself. I've talked to people in their most weakest, darkest moments,
No, I agree. I think as I wasn't the one doing the therapy, I wasn't the one giving the medications, but I was helping them get ready for their day. If they didn't get cleaned up and brush their teeth and feel like they were ready to go down for therapy, then they were going to refuse therapy and things like that. So it was a big role. And I do think that's a big advantage to being a physician assistant is they really, before you get to school, they want to see anywhere from 1,000 to 5,000 hours of hands-on patient care. And so a lot of those hours for me came from being a nursing assistant, a medical assistant. When you do spend a lot of time, you're the ones doing the EKGs, so you're talking to the patients, you're making them feel comfortable. And I do think now that I am a provider and I see the entire floor, because aside from working at the clinic, I do work at a big institution inpatient. I have a lot of respect for all of the CNAs, the nurses, the people just, keeping the hospital clean, all of it.
Yeah. So let's take a step back. So here you are. Okay. You're like, maybe I'll go into medicine. You work in an urgent care. But I suspect you thought differently about healthcare even before that. In fact, when I was doing my due diligence on you, I remember just Googling you. I saw this presentation you did from from college, right? I think it's you. Okay. And it was about GMOs, right? Was that you? I don't know. Maybe it's another Mary
I didn't know that
Dugandzic
was floating around on the internet. It's probably from high school.
And I'm like, wait a second. This person is like thinking like, okay, are GMOs something beneficial? Are they not beneficial? What are the harms? Are we thinking of other things? And immediately when I see that, I'm like, oh my God, I want that person. I want to work with that person, right? I want to work with that person because they're at least asking questions. It's not just like GMOs are safe and everybody should be using it. It's like, okay, are GMOs safe, right? Are they? And not that I feel strongly about GMOs, but like, I felt like there's something there where you're like, well, wait a second, maybe we should just stop and think about this. Right? Which I don't think a lot of people in medicine do. And here you are, fast forward, you go to, a sort of urgent care facility and you're being an MA and you're seeing docs and sort of patient after patient. And I'm sure you're witnessing the fact that people are not stopping and thinking, right? So what was that like just to see, before you started PA school, like what was it like just to see people in 5 minutes? What did it feel like to be there? I think I remember asking you a question. I said, did you affect anybody's life in your entire time at urgent care?
This was our first conversation. I think I was like hired at the office and I think I had to get your approval before I could officially start. And this was immediately 30 seconds into our phone conversation. I think the conversation we had, but I will say retrospectively, working on an urgent care was beneficial to the provider that I am today because I worked with MDs, DOs, PAs, nurse practitioners. I worked with so many different providers. And so there were good and bad skills that I noted and picked up on. And there were some providers who didn't give in to the pressures of, you need to see this patient. You're going to get dinged if they end up in the emergency room. You're going to get dinged if you take too long or do this. And they didn't really give in to those pressures. And I always I was always in awe of that because it's a very high pressure situation to see patients as fast as you can, as quickly as you can. And it was really honestly unfortunate to see the way that the institution worked, how quickly we had to work. But also I think that patients in the area really started to use it as a primary care, and that's not that's not the model that it is. There is no follow-up, but we had parents bringing their kids in for sports physicals because they had nowhere else to go. And so it's a fault on so many systems, like that their primary care can't fit them in within the week to get a sports physical, that they don't feel like they have anywhere else to go. And then it becomes this crutch and it becomes this pseudo primary care. And I think that's maybe what upset me the most about it, because yeah, if you have a UTI and you need to be in and out in 5 to 10 minutes, it's really not that complicated. I think urgent cares are great for that. But it was really this trying to use it as a primary care when that's really not what it needs to.
But can I ask you a question? Okay, so you're benefiting now, right? You're like, oh, as a provider, it was good to get that experience and see what it was like and some of the flaws. But out of the whole time you spent in urgent care, do you feel like you affected anybody's life?
Yeah, I think I'm just trying to play the positives, the negatives. Like I said, there's a role for urgent care. I think again,
I get it. But I mean, how long were you there?
Just over a year.
A year. And did you feel like, you helped somebody? Did you feel like you helped somebody?
Maybe 1 to 2 patients a day, truly like an urgent matter most of the time. And truly the reason that I did leave, I left after a year, was because I was working through the pandemic and we honestly just became a COVID testing site. We weren't helping anyone. There was nothing that we could do unless they had pneumonia. We were just testing them, telling them had COVID and told them to quarantine, but you could have told yourself that, if you had a fever, go quarantine. And we were just being so overworked. I didn't feel like we were helping anyone. So after about a couple of months of that, that's when I left because I just didn't see.
So, all right. So you come to the crazies and you come to our clinic and, we do what we do, which is a little bit different, immersive, a lot of technology, texting, and, eventually you're like, okay, I'm going to go to PA school. And you get accepted to PA school and you get started. And that's really difficult. I don't think people understand how difficult PA school is. It is very rigorous. So what was the first couple of years like there? And then what was it like when you started to do clinicals? You had, some exposure at a rehab facility as a nurse's aide. You had exposure in an urgent care. You had exposure in our clinic. And so, tell me what happens during PA school.
Yeah, so PA school, for those who don't know, it's the first half is spent in the classroom. We're taking anatomy, physiology, physical diagnostics. We're learning everything, very fast paced, very intense. And then the second half of the program is spent doing clinical rotations. We do 7 core clinical rotations, seeing, everything, women's health, emergency, surgery. We got to do elective rotations and I chose to come back. I begged my program to approve your site. I really wanted to be primary care, but they said, we don't know exactly what he does, so it can't be approved as primary care. So it was my elective rotation. So I did go to another place for primary care and they focused on weight loss as well. But it was a lot of 15-minute visits. It was a lot of come back in 30 days so we can refill your prescription for your weight loss medication. don't really change that much how you eat, just kind of come back every 30 days and keep taking these medications. So I wasn't
And
really, again, I wasn't loving anything that I was seeing, and I knew I wanted to come back to your clinic. But it wasn't until I did internal medicine and I kind of got that continuity of care again, where you have these patients in the hospital for 3 days, 3 weeks, that I felt like I was helping people again. And I remember calling my mom, it was one of my last rotations, and I said, I think I finally found something that I like, because I knew I had to do something in conjunction with your office to just see a lot more patients and get more comfortable with my physical exams and reading labs and all those things. And that was internal medicine. But a lot of my rotations felt exactly like you were saying about urgent care. It just felt rushed. I didn't feel like I was helping anyone. I didn't know what I was supposed to do when I graduated.
yeah, I was kind of surprised your dean came and visited me. Is like, I just want to see what you, yeah, there's a student who like absolutely wants to come here. So I just want to see what happens here. And I explained to him what we do, and he was like, whoa, I was explaining to him, we remotely monitor, blood ketone meters, blood sugar meters, continuous glucose monitors, blood pressure, heart rate variability. We look at Holter monitors, sleep studies, all remotely, nobody needs to come to the office. We just can do it remotely, literally monitor the heart, sleep, blood sugar, heart rate. It's just all
I
remotely.
don't know. Yeah, I don't know if I ever told you this, but his wife does a point of care ultrasound
Yeah.
um workshop. And I was there one day and she asked me what I was doing when I graduated, and I explained the office I was about to go work at. She goes, is that the office that my husband visited? I heard he's the only doctor in the area that I've ever heard of using point of care ultrasound in a primary care office. And she was blown away, because it is such an incredible resource that not many offices are utilizing.
Yeah, it's really cool. Yeah, I mean it's a invaluable tool. And it's good to see, I was talking to Eric Westman about it. He's like, Tro, help me learn this, point of care ultrasound. And he's probably going to go take some courses and learn it. But he
Yeah.
told me every Duke medical student now gets a point of care ultrasound and is using a point of care ultrasound. And I think it's become more of a standard. I mean, you got training in point of care ultrasound besides our clinic, right?
Yeah, I got training in kind of doing fast exams. We did a workshop for fast exams, and then my program actually did offer a 5-week course in ultrasound elective, which I didn't take. I didn't have room in my schedule, but
Yeah. Okay. So here you are, you're kind of you're trying to convince your PA school that anyway, and they came visit us, they see what we do, and you came and you rotated here. But you had a rotation, I don't know if it was before or afterwards. And I remember you called me, you were like, Tro, I have to tell you what's going on right now. So talk to me about that. I think it was OBGYN rotation. So tell people what happened there.
so my OBGYN rotation was right after our rotation. So I had just come off of seeing so many patients get better, lowering their blood sugars, getting all this intensive education, nutrition, lifestyle, all these things. And I was fortunate enough to do my OBGYN rotation down in the US Virgin Islands. Half of it was in the clinic and half of it was at the only hospital on the island. And the patients we were seeing at the clinic were all considered kind of high risk. They all had advanced maternal age. A lot of them had gestational diabetes. And so almost every visit, by the second and third trimester, we were seeing patients that had tested positive for gestational diabetes on their glucose tolerance tests. And I think I sent you a picture. I actually pulled it up this morning because I was just in shock. These are 15-minute meetings, and they hand them this one sheet of paper that, in my opinion, made gestational diabetes so much more complicated. It was a piece of paper that on the left said, do not eat this, and on the right said, eat this. But they were such specific examples. They were, do not eat mangoes. Eat 3 fresh servings of fruit a day. Do not eat whole milk. Eat skim milk. And it could have been more general. I think the paper kind of overwhelmed a lot of the patients. They're like, I have to go out and buy these specific fruits, these specific milks. And I just think when you only have 10 to 15 minutes, it could have just been increase your protein, try to decrease your carbs. What are carbs? Instead, they went into really specific examples like do not eat mayonnaise, do not eat mangoes, and the patients walked away confused. And then on the flip side, I was in the hospital delivering these babies, and I delivered an 11-pound, 9-ounce baby because these women's gestational diabetes were so uncontrolled, and it's not safe for the patient, it's not safe for the provider, it's not safe for this baby. That we now know, gestational diabetes puts the baby at risk for future metabolic derangements, insulin resistance, type 2 diabetes. So it was just right after coming from your clinic, I know I was like blown away seeing something like this.
But they get much more, what's interesting is they don't even mention carbohydrates. They don't even mention increasing protein. What do they say about meat and eggs?
Oh, it was crazy. I don't know what it said on the do not eat, but on the eat side, it said eat up to 3 hard-boiled eggs a week. And I think that was the only indication of anything about meat or protein. I think they said avoid fried meats, eat, broiled and baked meats, which sure, yeah, avoid fried meats, but nothing about just increasing protein, increasing satiating foods, cutting out juice. Like, I don't know why. Then they also gave scheduled eating times and like insisted that they have snacks twice a day. Snacks should be popcorn or crackers, and so little information, but at the same time, if you're only going to give that much information, it could have been completely different.
So walk me through. So like, okay, here you are, you're seeing all these different ways of, practicing medicine. And so you end up, actually, we should probably talk about before you graduated, we worked together on a paper. So maybe we should talk about that a little bit because, it's not very common. I know, is research promoted in sort of PA schools? Is it something that you guys are like told to participate in, or it's sort of like an asterisk?
It's really not as promoted as it is, as I know it is in medical schools. Having done some of my rotations with medical students, they were all really trying to push for research, and it wasn't something that I didn't want to do. It just wasn't really on my radar until you brought it up.
Okay, so then we see this case, and we work together on this case report. So tell people a little bit about the case report because I think it's something unique and interesting.
Yeah, absolutely. So it was a case report about a young man who had undiagnosed Cushing's disease. And for those who don't know, Cushing syndrome is any reason for you to have elevated stress hormone or cortisol through your body. So some indications might be steroid use, exogenous steroid use. It can be brain tumors, adrenal tumors, multiple different reasons that it can happen. And this man was young. He was struggling with obesity. He was managing his own obesity with a low carb diet. He's a big fan, I think, of Eric Westman's and following along on all of these changes. And eventually, he still struggled with his weight and he went carnivore. But the way he kind of, I guess, came to us is he also was struggling from uncontrolled high blood pressure. And he was a young man and he was on 3 or 4 different classes of hypertensive medications. And eventually he went to the emergency room. And they did a basic workup. They looked for big causes of it, but basically they kind of shook their heads. They said, we don't really know, follow up with the cardiologist, follow up with the primary. And he kept kind of getting tossed around until he came to our office. And
yeah, I was looking back on the records, and a couple of times it was like, we should look into secondary hypertension, but eat low calorie, eat low salt, have a nice day.
Yeah. And they did do some workup. I know they got like a ultrasound of his kidneys. It wasn't renal artery stenosis. It wasn't those things, but they still didn't really, I think the biggest thing was take the time to listen to him, because if you would know that he was also struggling with his weight, he was making all the right changes. He initially did lose the weight and was still struggling with it. And for those listening who don't know, like a big, big symptom of hypercortisolism in Cushing's is abdominal weight gain, face weight gain. It's also high blood pressure, other things like that. But if they had the primary care team or whoever it was kind of took the time, and the way we kind of figured it out that it was Cushing's was he was showing us his Instagram and he wanted to show us how much weight he had lost. And while he had lost weight, he had kind of started to gain it in his face. And he had bruising or striae, not right, bruising, kind of like stretch marks on his stomach, which are all hallmark symptoms for Cushing's disease. And that's kind of what prompted the workup. But it took 4, 5, 6 doctors to kind of take the time to listen and get there. And then once we got there, I think it kind of spiraled into this, how does low carb affect this hypercortisolism? He was able to manage having a pituitary tumor, which ended up being the cause of his hypercortisolism, for months to if not years. And it was under control because a low carb diet can help decrease a lot of the symptoms that go along with Cushing's, like high blood pressure, elevated A1C, low HDL, and his numbers like weren't that crazy, probably because of how stringently he had changed his diet. He was full carnivore by the time we met him. So
yeah, I mean, I think we also learned a lot, right? We became sort of experts of Cushing's along the way. We had to, before we send somebody off to so Cushing's, just to reiterate for the listener, it's exactly what you said. It's an inappropriate production of stress hormones. And we test for that in certain ways. We look at the urine. We look to make sure that there's a high production of those stress hormones in the urine. We look to see that it's there in the blood. Oftentimes we get imaging to see where is it coming from. Is it somebody taking the steroids and that's raising the stress hormone? Is there stress in somebody's life? Is there a brain tumor? Is there a that tells the adrenal gland to make more stress hormones? Is there an adrenal tumor? Is there an adrenal tumor making more stress hormones? Sometimes it can be challenging to find where this is coming from. And ultimately, if you think it's something in the brain, often it could be a very small tumor in the brain that is prompting the adrenal gland to make more of the stress hormone. Before you go do brain surgery, you want to make sure that that's the cause. And you actually, before you do some surgery, you go in and you look to see if it's that area, if it's actually releasing the hormones you suspect. And, we went through the process of understanding all this and, trying to figure it out, working with surgeons, working with endocrinologists, working with endocrinologic specialists, and, ultimately, writing it up. But you're absolutely right, and then we dug into the literature and you found some interesting stuff that, hey, it's not the first time that a ketogenic diet's helped manage high cortisol levels or decreased cortisol levels, which I was impressed by. Yeah. So, that's kind of, I remember reading your PA school's Marist newsletters, and they showcased it, like Mary Dugandzic wrote this case series. Okay, so what happens next? Where does life take you next?
Yep. So I finished my clinical rotations. And just like in medical school, after we finished PA school, I sat for my boards. And I worked on getting licensed. And now I work part-time at your clinic. And I work full-time at a big institution in the city. I do medical oncology. So I manage patients who have cancer diagnoses. I kind of am the gatekeeper when they get admitted to the hospital, talking to all the different specialists and managing their medications, their day-to-day. And it's been quite the adjustment. I kind of didn't realize just how sick my patients would be, but it's been a really good learning experience. I am reviewing labs, imaging. I'm talking to interventional radiologists, pulmonologists, radiation oncologists, learning all the ins and outs of cancer. But a lot of these patients do just have stuff that any person might have: pneumonias, systemic infections, sepsis protocols. So I'm learning a lot. Yeah.
Walk me through what it feels like to be like a new PA, like out, I remember when I first really started caring for people, just the absolute shock I went through. I mean, absolute shock. You come in, you're a med student, you're like learning everything, reading everything, doing as much as you can. And then, you just get shocked. All of a sudden people's lives are in your hands, and you feel alone, right? You feel like you befriend the nurses and the respiratory technicians and the physical therapists, and just anybody help me gain some insight so I don't hurt anybody, right? And that's the feeling I remember having as an intern starting off. And you look around, and people are just like cold. People are dying, and they're like, they don't care, and they just, see you later, call me when things are okay. And or call me if something's really bad. And you're taking care of maybe 20 or 40 patients at once, and you're like, how is this even safe? But that's what it's like, working as an intern or a resident or even a hospitalist or a hospitalist PA or a hospitalist NP. So what was it like making that transition?
I think every transition has been so difficult, like jumping into PA school and then jumping into clinical year. And then this has definitely been the hardest transition. I think maybe I am on my way up a little bit, but it's a big transition because now you learned everything textbook wise. And like I mentioned, my patients are very sick. And I think this is true for the general population, but especially on my floor is you learn something textbook. You give this medication and this is supposed to happen. But that's rarely how it actually happens, especially with my patients, because there's so many other factors at work. Their kidneys aren't working, they're weak from their chemo, they're neutropenic, all of these things. And so it's a lot of risk benefit analysis that as a student, you're not the one doing those things. As a medical assistant, you're not doing that. And I think the hardest part is, there's not always a right answer, but you can try to make the best decision. And kind of the art of medicine, having a sort of even working on that kind of like gut clinician feeling of something's not right, like the numbers look fine, but something's not right with the patient. And I think that's a big issue in big institutions is very rarely do you have the time to sit down and talk to the patient, get the full story. You're kind of going off of bits and pieces. And when you can take the time to sit down with the patient, a lot of the times it's easier to kind of parse out that feeling of what is your gut telling you. They taught us in PA school, like the diagnosis, 80 to 90% of the diagnosis is in the patient's history. You can kind of parse it out. You confirm it with a test or a physical exam, but 80 to 90% of the diagnosis is going to be in the history and physical. But when you said you're taking care of 20 plus patients, all very sick, it's hard to do that. And it's hard to get, like good consults, and it's just difficult.
Yeah. I mean, I remember, I was a resident and then a chief resident, and it was a struggle. It was a struggle, and we would know it every year after year. You see new residents come in, and and we would have to try to prepare them mentally, because we knew what was coming. You're going to be shocked. You're going to be overworked. You're going to feel unsupported. You're going to feel anxious. You're going to not know what to do, and those are like tough feelings to process. They're not easy. And then in front of you, the whole human element, like there's people in front of me dying. These are their last moments. I don't know what to do. I don't know what I can do for them. Why does nobody care? Why does nobody care?
Yeah.
It's just a lot. It's a lot. So can you talk to me about that? Just like what does it feel like?
I think so I think everything I just talked about is probably something that every new graduate, resident, intern, even when you're attending, those are probably all feelings that everyone has. Um, Unfortunately, a lot of my patients don't always have that many medical options left. So I think even more part of my job than most people's job is
Because you
risk
have a sick population, right? So
because
you
of,
have like a really so like in our clinic, we have the patients with diabetes, but in
yeah.
your sort of hospital, big, clinics or big hospital setting that you're involved in, these people are really sick,
Yeah.
right? It's like basically like an ICU. They have, terminal cancer, that type of thing.
A lot of it. And then, so, I like there to be an answer. I like there to be, I'm going to give them this, they're going to get better and they're going to go home. But unfortunately, that's, we're all going to die. And it's how do we extend their life as best we can, but sometimes that's not how it goes. So, I feel like something that commonly happens is my patients aren't eating or drinking. They're on fluids. Their kidneys start to fail. They have fluid overload. Their kidneys are failing. Do we give them Lasix? It's just a constant cycle of how much do we do and how much can we help them? And it's been difficult to kind of wrap my head around at some point. There's not always much more that you can do. And unfortunately, I mean, there's issues with everything and kind of if the patients want to go home, but then they have insurance authorization stops and it's not safe for them to go home or they're waiting for approval elsewhere. And then fortunately, a lot of my patients have to spend their final days with us on the unit for many reasons. And
That's a lot to sort of process. I think, nobody wants to lose hope, right? No patient wants to lose hope. And many of them haven't had the chance to talk about, what should we do in those last moments. And here you are, fresh in your career, and I'm sure you're being asked, like, go figure out what these people want to do in their last moments.
Yeah.
And that's a hard discussion.
Yeah.
Sort of
have a lot of very hard discussions. Multiple times a day, I'm, giving really bad news, which I also think is something that, yes, we learn how to do in school. We learn how to be sensitive and educate the patients on like the realistic prognosis. But I think very rarely do providers have to do it as frequently or to the same degree that I do. And we're also dealing with a lot of people's families too. A lot of these people can't make their own decisions. So you get into those, a lot of my patients are past the point of making their own decisions. The disease has just progressed too much. And so then you're dealing with the family and then also, the ethical and legal decision making, like who can make these big decisions for them, which is not something school prepared me for, but I think that's just life.
Yeah, I mean, it's my school didn't prepare me for it. I think when you become that primary decision maker in a hospital setting, that's the only time where you can learn that, right?
Yeah.
And but one of the things I remember as a resident being a little uncomfortable with was, on one hand, you're like, we should really figure out what this person wants, right? In their last moments of life. God forbid that ever happens. We should really figure that out, right? And you get really good at sort of doing that, and you also get good at figuring out what the family wants, and does that align with what the patient wants? Because if a patient becomes really sick and they can't advocate for themselves, then it's sort of like, what does the family say should happen? So not only do you want to understand what the patient wants, you want to make sure that the family hears it and can reconcile it, and so that's a skill, right, to sort of do that. But then, I noticed this thing in the medical field, and it always made me uncomfortable. It was like this subtle push amongst all the healthcare providers that, like, we like to and it always made me feel really slimy and sleazy. But and I remember feeling it constantly, especially in the ICU setting, which is, like this subtle agenda to like get people to say like, do not resuscitate me, or I just put me on comfort measures. Like that was the goal we were trying to attain. We were trying to make it so that, and this is me just editorializing how I feel. I'm not saying that it actually happened, but it always made me feel very uncomfortable. Like it was this path of least resistance among the ICU doctors, among the doctors, among the nurses. It's like, oh, we got to make this patient comfort measures. Like that's not your role. That's not your job. Your job is to figure out what the patient wants. Like what are the patient's goals and wishes? Your
I think
job isn't to convince them of what you want for them.
Mhm. I think
Yeah.
I think in conversations, seeing so many patients, I see patients get resuscitated and intubated all the time. And I think it's such an important conversation to have. But I think it's like with anything, it's with what intention are you coming at it with? There are definitely providers who come at it with, we don't really want to have to deal with this anymore. We don't, like they're terminal. Let's see if we can get them to do comfort measures versus truly like they're at a point where it might be uncomfortable to do chest compressions for the patient, or it would be uncomfortable to be intubated. And I think it depends on where you're coming from. There's definitely, I know we were talking about that feeling of kind of feeling like you're pushing for it before it's necessary, kind of just to move on.
I don't even feel like there is a time where it's necessary. All that we need to do is ask the patient what they want and do they understand what that means. But I felt like, in that ICU setting, like there was this pressure to achieve a certain, and I detested that. I detested the fact that everybody thought it was a goal to sort of make somebody a DNR or make them a comfort measure. It made me feel very uncomfortable. It's like, no, that's you being authoritarian. That's you thinking that you know what's best for somebody in their family. And it should never be that way. It should be, give them insight, and let them make their own decisions, of what they want, right? Your job is to educate. So if you're concerned that chest compressions are going to be uncomfortable or whatever, like your job is to communicate that, not to just say that you know what's right for that person. I used to tell people all the time, it's ultimately a value judgment. And I think doctors are hard accepting the values of other people, right? Like it's hard for doctors and medical institutions to accept the values of other people. And I think, you've probably seen that play out more than once in your career, right? Like I've certainly seen it in my own career. When I was a medical resident, I refused my flu vaccine and not that I didn't think, it had some benefit in some people, it just wasn't a benefit in me. Right. And I faced a lot of sort of, like, look, eventually they made me chief resident. They realized how well studied I was. But I faced a lot of hardship, right, for my values, right, for the values I had. And because I feel like there's a lot of sort of authoritarianism. So tell me, have you, like, not that, you're like, forget about your own institution right now, like talk independently about other institutions, I guess, or just overall, have you sensed that sort of lack of just, accepting other patients' values, even if we disagree with it?
Absolutely. I actually had a patient at our practice. I was doing a medical onboarding last week, and I agree. I think doctors kind of just say, take this medication. This is what's best for you. I went to school. Your blood pressure is high. Take it. And, I said, has anyone ever discussed a statin with you? And she said, oh, yeah, my doctor prescribed it for me a year ago. And I said, I'm not judging. And she said, I shouldn't take it. And I said, I'm not questioning why you didn't take it. Is there a reason? I'd like to know why. Did you take it and you had side effects? Did you take it and then you couldn't afford it? Did something happen? Is there something that I'm missing? Did someone in your family have a bad experience with it? Because so many times the doctors just prescribe it. The patient doesn't feel like they understand it or they have an issue with it. they don't feel like the provider's listening to them.
I think most of the times doctors don't even understand it, to be honest with you. So so they're just like number bad, here's med, right?
Mhm.
So, you
Yeah.
know,
So,
but yeah, I'm just curious, what did that person say?
I can't remember off the top of my head. She just said she didn't feel like she knew enough about it. And I was like, okay, so I'm glad to know that, maybe we could have a conversation about this. If your risk remains high, we can like continue this conversation. And she was agreeable to it. But I think very
I think
rarely.
that's, I mean, you hit the nail on the head. Most people just want to know what's the risk, like what is the potential to benefit from this, right? And that's a unique sort of discussion for every person, right? So, like, if I give you statin right now, is there any benefit?
Right.
Right? Probably not.
Probably not.
Right? Right? Is there any benefit for you to have a statin right now? There's no evidence to suggest there's a benefit in a healthy person, young person with no, severe metabolic. There's no evidence, right? But take somebody post heart attack or post stroke, there's stronger evidence.
Mhm.
Or take somebody with a very, very high CAC. There's a bit stronger evidence that those people are more likely to benefit. Does that mean that they're not going to get side effects?
Yeah.
No. And whether if a doc told me, hey, you're going to have muscle aches and you're going to have joint problems and you're not going to feel great, right, on this medication, would you take it? I'd be like, no. Well, they're like, well, what happens if you lived a week longer in life? Would you still take it? My answer would be no. Like, well, what about a month longer? You'll get a month longer, but all you're going to get is muscle aches. And I'm still like, probably no. So like,
but that's your decision. For some people,
exactly.
a month of
they're like, I'm gonna take this month, like give me that month right now.
No, and I think another thing, like just coming at like my aunts and uncles are at the age where all their doctors are pushing statins, and I asked them, I'm like, oh, what are your thoughts on it? And they just like, I don't want to take a pill every day, I don't know what's gonna happen. And I'm like, well, you try it, you try it. If you get side effects, I feel like no one talks about the fact that you might not be on it for the rest of your life, that at some point you could decide to stop taking it. And then also off the muscle aches, I feel like I'm shocked that no one ever knows to take CoQ10 as well, something so simple, like a little bit of patient education, to kind of.
Yeah, if you're going to prescribe a drug, like try to mitigate the side effects, the known side effects, right? You can even run genetic tests. I mean, we've run them before in our clinic. You've seen them. We can sort of predict who'll get myopathy. And honestly, in my opinion, I've seen most patients prescribed a statin probably didn't need it. Probably didn't need it. Okay. Meaning like it was just reflexively prescribed for a mildly elevated number. But then the flip side is we get patients in our clinic who have a very high CAC or they've had a heart attack in the past where, at least you want to think about this in much more depth. You want to like go through it. Let's figure out what's the potential for you to benefit. At least let's go through those numbers and, figure out like what is your, relative and absolute risk reduction, right? Like those simple things like, why am I taking this medication, right? And we do those as clinicians all the time, right? Like if somebody has pneumonia, right, and they are over the age of 75 and they're short of breath, well, that's a, that's almost a 1 to 5% chance of dying. So do you want to take an antibiotic? Well, yeah, your risk is really high. Okay, well, if I'm younger and I just have some cough and, I'm otherwise healthy, do I need to take an antibiotic for an upper respiratory thing? Well, no, right? You don't need to, right? Is there some benefit if it was a bacterial, upper respiratory infection? Yeah, maybe. But my risk is so low, the antibiotic is going to cause more harm in me than good.
Yeah.
Right. And I think that's the problem is docs aren't able to do that. It's like, here's why I'm prescribing the statin or why I recommend it. They can't explain, like, here's why you should take it. And you know what? Even if we give somebody an explanation, look, if you tell me there's a bank down the street that's going to give me 0.1% more interest, I'm not leaving my bank to go to that bank. 0.1 is not enough for me.
Yeah.
right? Is it enough for you?
No,
No.
I
I mean,
don't
but
need
now if you're giving me 5% more interest, well, now I'm like, okay, maybe I'll do that. Maybe I'll think about it, you
Yeah.
know? Anyway, your thoughts on that?
No, I completely agree. I think it's all about, at the end of the day, we went to school and we can explain all of these things. It's our job to think about risk, think about problems, but at the end of the day, it's always up to the patient, it's their life. And so just knowing that you did the best that you could, taking the time to explain medications, risk, benefits, side effects, lifestyle, all of these things. And then at the end of the day, it's up to the patient, and we definitely have to respect that. I think that's where a lot of our patients at the clinic come from. If I could tell you how many times I say, what are you doing here? What's your goal here? They say, well, I just want someone who's going to listen to me. I want someone who's going to explain things to me, or, not get upset if I don't take this medication. I say, well, absolutely, let's just have a conversation about it. And so I think that's actually, a huge problem, because that's kind of why all of our patients are with us.
Absolutely. Absolutely. Listen, so how do people find you? Well, first of all, if there's a patient listening who, wants to, wants you as their provider, they certainly can come to our office and they can see you. But let's say they want to interact with you, find you on social media. Can they do that?
So I am on Twitter. I do not tweet nearly enough or nearly as controversially as you do, but
Maybe that's a good thing.
my New Year's resolution is to be a little more active. So I am on Twitter. I think it's at Mary K Dugandzic. My last name Dugandzic. And I'm also on the Dr. Tro app. You can see me on Tuesdays when I'm not working. I don't know when this podcast is coming out, but doing the 19th this month, and I'm around on the app to do meetings. And yeah, I'm licensed in about 10 states right now. So
And growing. Okay.
Yeah.
Awesome. All right, guys. Thank you so much, Mary. Thank you much to the listeners. I think they'll definitely enjoy this.
All right. Thanks for having me. This is great.